My role within CCAC, so I'm a registered nurse, that's my background, but now I worked as a care coordinator for a couple of years, but now I manage the oncology team, the acute care team, and the rehab team at CCAC. So that's why Dan's email ended up on my desk, so because I have the oncology team, and this seemed fitting for the population that you had. So I think people are still, in your support group, people are still on radiation and chemotherapy sometimes. And I guess some are palliative as well. Now we do also have a palliative care team at the Champlain CCAC, which is care coordinators who are specialized in end-of-life care and coordinating those services. So you might know the agencies like ParaMed, St. Elizabeth, Bayshore. So basically what CCAC does is we assess patients once we get a referral. That referral can come from a family doctor. You can call yourself the number and say, this is my problem, can you help me? And a care coordinator would decide what kind of services you would be eligible for. So we have nursing, which is what you had before at the clinic, I believe. Physiotherapy, occupational therapy, we have personal support for people who can't bathe.
We're usually told that we have to be referred by a doctor.
Right, so
this is what we've been told.
Yeah, so it depends what you need, but you can actually self-refer. So yeah, what Dan was saying is that they were told that they need to be referred to the CCAC by a doctor.
Yeah.
So
I'm trying to.
Yeah, that's what happened to us.
Yeah, so it depends what services you need. So if you need medication to be administered, a doctor needs to order that medication. So in that case, we would need a referral from a doctor. A catheter, we also need a medical order because we need to change the catheter every month. We need to do the catheter care and do the teaching. But if, let's say, you've had a fall at home or you're weak and you're not feeling well and you think you may need physiotherapy, you can actually self-refer. You can call yourself and say, this is my problem. You have to have a valid OHIP card, so you need to give us some information when you call in. But we have representatives at the front desk that take all that information and forward your request to a care coordinator who would call you back to do the assessment with you. So you actually don't need a referral from a doctor sometimes. Also, some people have been discharged home with a catheter and for some reason the physician forgot to send a referral or it never got to us for some reason. In those cases too, you can call us and say, I have a catheter, I need a nurse to help me. I was at the Cornwall Community Hospital and now I'm in Ottawa and I don't have any help. So in that case, we would reach out to the doctor. We would reach out to the hospital.
No, because he had a catheter coming out of the hospital.
Yeah.
And so we were told, the care force said, are you going to take care of the catheter? No, we need a doctor's order.
They do need a doctor's order.
But the catheter was already there.
Yeah, I know. So for a nurse to do any kind of intervention with the catheter, anything that's internal, we need a doctor's order. So if you would have been admitted to care for, or if you would have wanted nursing care for the catheter, you would call CCAC. We're the ones who determine eligibility. And then we would find the doctor or we would reach out to the hospital to get an order from one of the doctors. Or we would say, go see your family doctor and get them to send a referral to us. So for certain things, like I was telling you, if we have to give medication, if we have to give injections, catheter care, anything that's internal, we need a doctor's order because a nurse can't access a line, can't give medication without a physician to sign it off. So that's why you were in that situation. But what people don't realize is that if they're having trouble bathing, if they're having troubles getting dressed, they can call us themselves and request some information or ask for an assessment. You don't necessarily need a doctor's order. We also have nurses that can refer you. So if you go see a nurse practitioner, or if you go to one of the clinics that has nurses, they can refer you into our program. So it's quite complicated, but
Okay,
do you have questions?
yeah, I have a question. You talked about Bayshore, Care
Yeah.
for,
She didn't say care for, I was listening.
But Care4 is one of our providers.
yeah,
Okay.
so, but people don't, I mean, we don't know which agency.
No.
They absolutely don't know, and is it depending upon where you live?
Yeah. So
Okay,
it's dependent on multiple things. Let's say you need nursing for catheter care. The assessment would be done, and then we would send a request to our nursing agencies to see you. Let's say you're in Orleans. There's a clinic close on
St. Joseph.
St. Joseph Boulevard, and that's a
Which railway?
paramed-run clinic. So if, let's say you live in Orleans or Blackburn Hamlet and that's the closest clinic to you, we will ask paramed to take over your care because that's the closest to you. If you're very, very sick and you can't leave the house, or you have an amputation and you're bedbound and we have to send you a home nurse, then we look at all the agencies within your region and we ask one of them. So we work with about 7 different agencies right now. There's St. Elizabeth,
Oh, yeah?
Bayshore, Care4, Paramed, RC Access, there's Community Care, there's a ton.
okay.
But those are contracts with us. So when we ask for nursing, we subcontract to them to take over the contract.
One other question.
Yeah.
When he had the catheter,
Mm-hmm.
the nurse came to our place.
Okay.
Okay. Then I got sick.
Okay.
I went to the hospital, I had surgery, I had a bandage and got infected, I mean, the works in it. And then they said, okay, you're gonna go, CCAC will take care of you. Who? But that was a few years ago.
Mm-hmm.
You know, they said, no, and I was a lot sicker than when he had the catheter, believe me. And they said, no, we're not going to your place. If you're mobile, you have a mode of transportation, you go to the clinic.
Yeah.
And you know, I was weak enough.
Mm-hmm.
Well, my hemoglobin was 37, so that I was weak enough to have stayed home. To me, going every day for changing the dressing, it was a lot.
Yeah.
So, what are the criteria for us going to the clinic or the clinic coming to us?
So that's actually been our biggest change in the past 2 years. So our referral sources has increased tremendously. Like just last year we had an increase of about 7 or 8% of referral rates. So right now we have 60,000 patients. So because of all those patients, a nursing to go into the home is just not sustainable for our organization anymore. So we've come up with this clinic model where people who are mobile, and like you said, the criteria, people who are mobile, who have transportation, and like even public transit is considered transportation, taxi is considered transportation. Really the in-home nursing now is really for people who are so immunocompromised that they actually can't go outside of their house. You would need reverse precautions, like those people can't go to the store, they can't go, they need home visits by their family doctor. Those are the type of people that have that immunocompromised status. Other people who are bedbound, so at end of life, who are not getting out of bed, or that are, because we even have people in wheelchairs going to the clinic now.
Once I was at the clinic,
Yeah.
waiting for a dressing change.
Mm-hmm.
In the poor receptionist, she was trying to convince, there was a lady, I assume was a lady, on the phone, who was giving transportation to an elderly person. And the way I could understand what was said on the phone, that it would take her an hour just to get that man from the house to the car.
Yeah, I mean,
And then.
that's severe mobility issues.
Yeah, no, but
It sounds like they
so,
have.
and then that person had to go there twice a week. She said, 2 hours just to get in and out of the car, plus the treatment, whatever it was, I don't know what it was. She said, it's too much, can a nurse come home?
Yeah.
And they said no. I mean,
But-
according to what I heard, they said no.
So if you were talking, or if you overheard a conversation in a clinic, that's just within the nursing agency. CCAC, who are not working in the clinic, we're the ones who determine eligibility. We're the ones who decide where people are more appropriate. So at that time, the client or the patient would have probably called his care coordinator to say, listen, like, this is my situation. And then, because that to me sounds like it would be appropriate for in-home services. So I'm not sure.
I don't know, I don't know all the
receptionist is not
details,
allowed
but
to
they said,
decide.
gee, an hour to take from the house to the
Yeah.
car. I mean, it was a big mobility
Yeah,
issue.
so our care coordinators, the ones who are allowed to decide whether you get in-home or clinic, they're not receptionists. They're nurses, occupational therapists, or physiotherapists, or social workers, or speech-language pathologists. Those are the 5 different professionals that are allowed to be a care coordinator for the Champlain CCAC. And they're the ones who determine, okay, based on your history, based on your file, based on what you've told me, based on, we use a scoring system that's been developed by the government. Based on all of this, I think you're appropriate for clinic. Things change all the time though. Sometimes you have a fall and then all of a sudden you can't walk and you're immobile, or your hemoglobin goes down to 30 and you're weak and you're feeling faint when you stand up. All these things happen and they change, but that's why the CCAC has you assigned to a care coordinator. So you would call that person and let them know what has changed in your status as a patient, and then they would be able to tweak your care plan. Care plans are always changeable. So if you've been assigned to clinic because you initially fit the criteria, that can change, and vice versa. Sometimes we get patients on our service who are, after a very, very big surgery, they're getting a lot of medication, they're getting physio, occupational health, they're getting personal support at home. So the nurses go home, but eventually they get better. At the time they get better, then we transfer to the clinic as soon as possible. That allows us to reach the most amount of patients for our region. Because the worst thing would be to have to put you on a wait list for a dressing change, which is not what we want to do. We want to be able to give care to the patients when they need it. So that's why we've had to come up with a clinic model. But the reception, whatever conversation you overheard, a receptionist is not allowed to say you're not allowed to get in-home clinic. That's not part of their role.
I think she referred
That's,
that
she must
person
I'm
to
assuming
the
she-
care coordinator or
exactly,
something.
and that person would be the one to decide if
But I
they're
mean,
eligible or not.
If I would have been in that person's shoes, it was a lot from what.
Oh, absolutely, I agree. That doesn't sound appropriate for our clinic. If it takes you an hour to get into the car, that's a warning sign to me, and they should definitely be seen at home. That's a 3-hour fare to go to a nursing
But then
home.
there's people in our support group
Yeah.
who receive treatment at home,
Mhm.
where other people are requested to go to the
Yeah.
clinic.
There's a lot
And,
of,
but I guess they can't tell them after they've been there for a while, you can't tell them to go to the clinic. They just keep it
Yeah.
up the way it is.
our program has changed a lot in the past 2 years. So if you've been admitted 4 years ago and you're still on service, one of the things that we are doing now is we are reviewing those files and seeing, okay, are they still appropriate for in-home, or can they move to the clinic? So we have been transferring a lot of patients who have been active to the clinic, but we have
Okay.
so many patients.
Yes.
The care coordinators on my team, some of them have 350 patients assigned to them. So
How could they manage that?
it's a lot of management, it's a lot of calls, it's a lot of managing. So we're slowly getting at everybody, but it's taking some time. And there's always new admissions, there's always discharges. So
And how about the evening and the night services?
nursing services at home are 24/7. If you're assigned to a clinic, and let's say you're with St. Elizabeth. They have clinics all around Ottawa and in Cornwall. If you are assigned to the clinic and have been going to the clinic twice a week for a year, and all of a sudden at 3 o'clock in the morning your dressing change gushes and you have drainage coming out of the dressing and you need assistance right away, you can actually call St. Elizabeth and they will send you a home nurse to deal with that. You don't have to go to the emergency room. So it is a 24-hour service and there's always a phone number. You're always given the provider that you've been assigned to their phone number so that if you have any problem at any time, weekends, evenings, overnight, you can call them. We want to prevent emergency visits. It's not good for the patients. It's not good for,
Well,
especially if you're known to an agency.
we were staying in a retirement home
Okay.
and my catheter blocked. And it was midnight.
Mm-hmm.
It never happens in the daytime.
Actually, you're right. All the catheter blockages are always on Irish numbers.
And so we called and somebody
How
came
could
from
this happen?
Orleans.
There you go. Yeah.
She wasn't happy to be there, but
Yeah.
she did the job.
Yeah,
Very
and
well.
all of our nurses, like all of our agencies, have people on call, exactly
Yeah.
for that reason.
Yes.
Because that, you could have had to take an ambulance to the hospital, been
That's
sitting in
right.
emerge for 8 hours
Yeah, no,
before seeing
I
them.
wasn't well and
Yeah,
this was really helpful.
yeah, and even if you would have been assigned to that agency at the clinic, and you would have been going there, they would have sent you an in-home. Obviously, the clinic's not open at that time,
Yeah,
so they would have sent somebody in-home.
yeah, we did send somebody.
Yeah.
Yes.
So there's
Oh,
always,
yeah.
once you're assigned to somebody,
yeah.
you're always, that's your point of reference, and that's who you
Wasn't it
should call.
CCAC that we called?
Yeah,
It wasn't the care for.
If it was at midnight, CCAC were open 8 to 8 every day of the week.
no, that must,
So it must have been the agency.
I think was the emergency nurse, yeah. I don't think
The
that's it.
on-call, yeah.
I think we called CCAC not knowing, and then from there must have been a message saying, in case of emergency, call this number. And so we called that, the other
Okay,
number. I
okay.
think that's, if I recall.
And usually the retirement home that you would have been staying at would have known who your agency would have been at that time, so maybe they would have assisted you as well.
But
Not
it
sure where
was-
you were
It was
staying.
midnight though. It was-
Yeah.
that was it.
But that's the intent, like we try, sometimes we can't, depending, we have people in Barry's Bay and it's very, very remote area, so sometimes we can't always get to them. And sometimes patients just have such, like a bad event happen at home that our recommendation is actually to go to the emergency room. Sometimes people call us with chest pain and shortness of breath, and that's not something that we're prepared to
No,
deal with in the
no.
home, so we refer to the emergency room at that point. But that's basically the intent of our program is once you are assigned to someone, regardless of in-home or clinic, you can always get someone at home if you're in a bind, if you're in an emergency situation, that it's something that we can deal with, like a catheter blocking or a dressing being undone.
Have you got some questions you said
Yeah.
you wanted?
Well, now I understand,
Oh, okay.
because well, I got confused by the title. Because across the road on Jeanne d'Arc, there is a community, Champlain community, which has nothing to do, but
I
now
don't think it has any.
we understand that when we left the
Yeah.
hospital, going forward,
Yeah,
they recommended us to go through your,
okay,
at Orleans, and show me how
to do
I
the
couldn't believe that it would be allowed for a human being, instead of having done at the hospital, to do catheter. Catheter
Yeah,
myself, and I've been doing this since November, at home.
yeah,
So they showed me how to do it.
mhm.
At Orleans, they were nice. Their name was Suzanne, I think. Susan or something? No. Anyway, we enjoyed the service that we received at Orleans.
Oh, yeah.
But the Champlain Community Center near your place, or you said that you were not supposed to go there. What are they doing?
I don't know, it's just a center like any other But I got confused by the names.
Yeah, there's
He was confused with the name.
The names are right.
No,
there's an
that-
organization called the Centre Santé Communautaire. It's blue. It's like blue, but it kind of looks like the same C used here.
But when I
But
started,
they're a community center.
when I
it's
heard
not-
you talk at the hospital, they were nice. They said, I was on the one installed at the hospital.
Okay.
I went from off the street into the emergency, from the emergency into the room, and the doctor, there was a sign, he's from Vietnam and his mother died and disappeared to Vietnam. What a mixture that was. I was never explained because they did all their best trying to find another urologist that would take me in. They were all booked over the head. But this Dr. Carrier,
Yeah.
I don't know if that rings a bell. He volunteered, but he was on the impression that I knew a little bit about
Yeah.
bladder problems. I didn't know nothing. Every time I asked him a question, he thinks I was laughing at him, making jokes or something. Anyway, I told him one day, I says, as far as I'm concerned, parts of your body, if you want to see, your eyes opens up and see. If you want to urinate, you go to the toilet and do it. But I didn't know, and I never could understand that your bladder could stop working.
Yeah.
Yeah.
Now I know now.
Yeah.
But these people help us. They show me what to do, how to do it.
Yeah, and they called too, and they told us which gel to use because it was
good.
painful at the time.
Yeah.
We knew nothing about it.
They were
It
very
was quite a
careful
shock.
to assist us where to go and what to buy and what. If not, well, see the doctor, we could have gone back, but we didn't need to go back.
I'm
But
happy to hear that.
Yeah.
A lot of patients are very overwhelmed, especially when they leave the hospital with a new diagnosis. You don't really know, if you're not in the medical field and you don't have an understanding of
It's
what's
a
going
shock.
on with your body, it's a huge
it's a shock. It's
Oh.
a real
So,
shock, yeah. It's devastating.
And another challenge that we have is that we don't work for the hospital, we work for the
Yeah.
community. So sometimes the hospital says they will contact you, but we're in a lot of the hospital sites now, but we don't get to see every single patient in the hospital. So a lot of people still don't know about us, which is
Well,
good while we get to do these little sessions where we can do some education and
at the hospital,
Let
the
people know who
nurse
we are.
who was with the doctor right away contact you.
good, good,
And then they contact, you
yeah,
know, so it was well done,
good.
but
Yeah, that's our intent. But there's a lot of patients that go through the hospital, so we do the best that we can to reach people within a certain amount of time.
I didn't require any assistance or service at home.
Yeah,
I went to the clinic,
yeah,
how many times, 3 times, 4
2
times?
times a week.
We only had a
You
2-week,
were familiar with,
Here.
because you're afraid. You
yeah,
have a stranger in your body and you're afraid to hurt if you
Yeah.
push. So it's no fun,
no, it's not fun.
but it's better to do it that way. It's normal.
Yeah,
You have no bag because the bag really damages skin.
yeah,
So it's better to self-catheterize than wearing a bag.
but when he gave me the choice, he said, what do you decide?
So what do you have now? A catheter?
Yeah.
No bag.
No bag.
No,
He
no,
does it himself.
so you do the catheterization a couple of times a day or once a day?
oh.
No, no.
Uh,
Since he had the stand,
oh, yeah, this,
Oh, I had one installed,
yeah, he had the stand, and after that he had another stand in the,
What is a stent?
stent is,
ça must
you probably heard,
called for
Yeah.
the patient.
they get operated for heart or
Heart,
something,
yes.
you put a stent. But when they
It's a
said,
vessel, isn't
if,
it?
Yeah.
if
Yeah.
there's a blockage, it's like a little piece of a straw
yeah,
that they
yeah,
would put in the vessel to open up. So then there would be flow,
Yeah.
blood flow.
when he told me
urine flow.
a stent, like I said before, I was transferred from one doctor to another without knowing what was wrong, other than taking their orders and do what they were asking me to do. But anyway, a stent for the heart can stay there for a long time.
Yeah.
But if you put a stent down below here where the acid is, It has to be removed after
Oh,
a month or two. It's gonna start to disintegrate.
Then you have a problem.
So it has to be removed. And after the operation, the doctor would come over and say, "Oh, forget now, we have to remove that thing," which they did last
Last Wednesday.
week ago. And, but while it's there, and one few days after it's being removed and all that, for your kidneys and everything to go back to normal, it's a transition you have to go through.
is that to help the catheter go in, or what?
No,
No.
that works inside.
It's
The
just
The
like-
catheter is only to empty your
It's only.
bladder. That's all it does.
Yeah,
It's the
so,
stent.
so
Or
just
the
like,
catheter.
That's another thing.
Mhm. So some people have catheters,
Yeah.
because there's no stricture or anything. But for people who have a blockage or stricture, which is basically that vessel or that tube is too small that they can't urinate, they do stenting, where it
Oh.
basically opens up so that there can be active
Yeah.
flow again.
Oh.
That's,
You know, when they first told me, I says, "I'm gonna do the catheter myself." And you see yourself in a shopping center somewhere,
Yeah.
at Jim's, in a place where can her and I enter the men's room because they were showing us how to do it. There's a lot of things going through it. I says, "Holy cow."
So
Yeah,
that's over.
if you have a stand to open the ureter, the tube, because there was a blockage there,
Urethra, not the urethra.
the urethra, okay.
Urethra.
Okay, if there is a stand there, why do you need to put a Foley catheter in?
catheter
It's not a fold.
is used from the end of your penis into your bladder
Mm-hmm.
to empty your bladder.
Okay.
The bladder is from what I'm told, it's just a piece of rubber or
A
something
muscle.
that receives the urine from the kidney
Yeah.
Mm-hmm.
and it opens up and fills up. And when it's full, under normal condition, it would compress and tell you, me there, you go and urinate.
Mm-hmm.
But now it gets full, but it doesn't compress to go out, you can't.
Okay.
So then you start to be choked here. It hurts.
Mm-hmm.
And then you know that it's time to do your catheter. Catheter. Now you put your catheter in, past the prostate and all that, and then you start to run. And once that's done, oh my God, you ever feel good. It's got nothing to do with the stent.
No?
So
Mm.
even
No.
with the stent, you can still have urinary retention issues.
Right. Right.
Okay.
So you would still have to catheterize. It's just not a Foley where it stays in all the time and drains into the bag. You would tap into it with a clean, it just doesn't have the bubble on it. It's just a straight
But
catheterization.
all the thing that's done at the hospital is all done the natural way. It's unbelievable. The cameras, they put cameras in there. I was laying down in bed one day when there was a screener just right next. And I says to him, I said, "What's that there?" The nurse that was there. He says, there was it's just like a little pair of long nose or something. And she says, "We're going in to remove your catheter." And I said, "Where is that thing?" She says, "That's the inside." The camera is showing us exactly that's the inside of yourself. But they put some kind of a gel,
Oh, yeah.
but you get a very funny feeling of that.
Yeah, when they do
They don't give you no
cystoscopy-
needle, they just put something inside, and you think you're going to take off or something. Oh, but then you're frozen.
Mhm.
They put camera in there, did it.
Yeah, I had that done.
Mhm. They've come pretty far with their
Oh, it's amazing.
urology.
Dextrose now.
But they call that the day operation.
Yes.
It's installed from, you have to go to an operating room. there's 11 people in there and they showed it, and then to be removed, it just needs to go in and remove. And they showed me what you said, what I cut it here, it's
If
only
I
that
get it
long.
down, then also the stand.
Mine was a,
That's 10, sorry.
mine was a little different. I had a burn from a radiation, and they went in and cauterized that area that was bleeding.
Oh,
And it's a little different, but it's the same principle, exactly the same principle. It was up on the screen.
Yeah,
Yeah, you could see it, you could watch it.
no fun.
No fun, no, I watched it.
Like,
She sat
I
there and
watched
watched it, yeah, she sat there and watched it.
oh yeah,
Oh, yeah, she did, I wouldn't
Well,
watch
and,
it.
I mean, and Dr. Morash was really nice, he was explaining to me, he said, this is this is that.
yeah.
Yeah, it was really nice, that was fun.
Apparently, there's very few patient that accepts doing things, do the catheter at home, at a siblings at my age.
Yeah, no, I think you're right. I think you're right.
but you have a better life this way.
Yeah.
Like he could have a few hours without carrying bag. or
Because somebody
nothing, so
mentioned that
it's
a while ago,
marvelous.
how many times a day you said?
Yeah,
Right, you can't get out of it without under 4 times a day.
okay.
You don't realize before this, all this is happening to you, or it's needed, how many times a day do you go? You don't
even think about it.
You don't think about it.
Mhm.
But at the beginning, I was going 6 times.
Well, we were doing it every 4 hours.
Yeah.
We didn't listen to specialists, like say, only when you need it.
Yeah.
To us, it was
Get up in the middle of the
obligation.
night, that's nothing. But it's going back to sleep. It's a different thing.
Yeah.
Some of them like her, she can turn around and turn over and think she's going to get. But in my case, if it happens at 3 in the morning at 7 or 8 o'clock, I'm still awake.
Yeah.
To me, my night is over because once I wake up, I'm finished.
Mhm.
I used to work in train service, and once you wake up, you're awakened. Anyway, so but through these people, which I'm happy to announce that they did a lot of good things, and they showed me a lot of things. Now I do it on my own.
No, and that's our goal, is to get people as independent as possible, able to do it on their own. So sometimes people are surprised because they're like, oh my God, I can't do this by myself. But you would
But you're
surprise
scared
yourself.
because it's the unknown.
Yeah,
You know,
My-
how far do you go?
no,
My
exactly.
family, my friend, my neighbors, even today, and I've been doing this since November. Now
November
it's
6th.
4 or 5 months, 6 months. Now it's so easy. And when they hear me talk about that, holy God, they're almost on their knees and under the table. They
know.
can't realize, think that a human paid person can do a thing like this.
That's right, no, you're right.
When they go to let you go and leave you alone, there's no use even put $1,000 on the table and say, take $1,000 if you can pay. No way.
But at least you have control over when you get to do it. You can do
Yeah.
it whenever it suits your schedule, and you don't. Could you imagine if you had to go to the clinic every time?
Oh,
That's not a quality of life. You wouldn't be able to do
No.
anything. So.
No, we have a better quality of life
Yeah.
than like this, yeah.
Mhm.
But since they removed the stent in the left kidney, the timing is short compared. So
There's less,
probably
yeah.
playing in the body didn't help, I
What
don't
is-
know.
they did is they start at step 1 down below. 2, the bladder, and then you go in there and then they tell me, well, you have to, something has to be burnt inside there, and then into the kidney. Because what you drink, you see, like I'm going there, now that this is removed, they're gonna ask me to drink. And there's an instrument there, or a scan, that's going to see the liquid water going through the kidney,
The kidney, yeah.
whatever it does on inside there, and then into the bladder.
The bladder, yes.
And they measure all that, and they take time on it to see if the stent that was put in there opened up clear, did his job and
We're privileged in a way. In our life, that's the main thing to look at it.
Yeah.
Yep, no, you're
No,
right.
but I'm glad to hear that the CCAC was there to offer you some
Wow.
services. And another thing too is some patients don't have a catheter, they don't have an IV, they don't have a nephrostomy tube, but they're actively receiving chemo or radiation. For those patients, we do have some on service who all we do is pain and symptom management. So we teach them how to manage their pain and symptoms based on what the medications were given to them by their family doctor or by their oncologist. So that's another service that we do have. So if at one point you do start chemo and radiation and you find you're not dealing well with the symptoms, you're having issues, you're having to go to your doctor, you're having to go to the emergency room, that's something that we can assist.
Now, when you had the radiation and chemo,
Mm-hmm.
the nurse used to come twice a week at home.
Okay, good, and do some
The
teaching.
service was fantastic.
Because sometimes people need some hydration at home, or they would need just IV hydration, or they would need some injections for the nausea. So we teach that. We teach people how to give injections, just like
Yeah,
diabetics.
fantastic. It was cared for.
Okay, yeah, Care4 is very big agency.
Yeah, cared for at the time, about 7 years ago.
Okay, so, and now for the folks on your support group that are palliative, we also have a palliative team. So that team, the main goal is to keep patients comfortable and in their home. So at that point, we involve a lot of the family and we involve multiple providers at the same time because usually they require more assistance, like with bathing and getting dressed and getting ready, getting washed. So
Now this is for people at home?
these are for people at home
At home.
who are seeking palliative care
Yes,
at home, and
yes.
they want to pass away in their home.
Yes.
So we do have palliative service.
Is the waiting list long for palliative care at home?
No, there's no waiting list for palliative care at home. Basically, if you've reached that point where you're at end of life and you're not doing so well and you're not seeking treatment anymore, or you're so advanced in your disease that that's what you want, at that point the services are right away.
No,
You have another question?
are you on catheter right now?
Yeah.
Yeah. You do it yourself?
No, I have a bag.
Oh, get it back. That's a choice I had to make.
Mm-hmm.
And I think this, between this and asking me, are you ready to die? I thought there'd be no end of it. It's
Yeah.
I said, this goes back in September, no, November, was it?
November 5th, you start to catheterize yourself.
I think the problem was different though. Your problem was that you could not urinate.
No.
Okay. His problem, because of radiation, it damaged the opening, the sphincter.
Oh.
And this is what he said that he had to cauterize the blood vessels.
Yeah.
Oh.
By doing that, he damaged the sphincter or the door.
And so it's leaking.
So it's leaking.
All the time, continuously.
So this is not
No, it's not the
that's not
same.
an option.
No.
There's a lot of urinary, like when people think of urologists, it's such a very narrow specialty, but there are so many urinary issues that can
Yes.
happen.
But
So
in my case, it didn't happen overnight. Because through the months, I was seeing doctor for something else, for prostate cancer and all that. I told him, I says, your medication that you're giving me, would that be cause of my slowdown in my urination? He said, no, we'll see, wait and see. And so he'd see another doctor, but this was happening. When it did happen, sure, I found out because it ever hurt.
Yeah, does it ever?
yeah.
And I never had no thought in my mind that the pain I was experiencing was down to the fact that I was not. When I was into the hospital and they admitted me from the emergency into the room and they were going to operate, my belly here was just like a rock. It was that something was going to explode.
Yeah.
And they removed 800 milligrams.
Wow.
Milliliters, yeah.
of liquid.
Wow.
Just imagine, I'm sorry.
I think I had 400 at the most.
Yeah, your
when I
bladder,
was-
can hold up to 1,000 typically, but once you get up to 400, 600, 800, it hurts. It's not comfortable at all, so you try and drain.
We were at Saint Sauveur celebrating the birthday of my half-brother, 90-year-old, September, yeah. So,
Oh, wow.
and you don't go in the hospital in Quebec. There was a waiting list of 24 to 28
Saint
hours.
Sauveur, if you know where that is, the
So we
closest
drove back
hospital.
home with Tylenol.
Saint Jerome.
Saint Jerome, which is.
So we phoned Saint Jerome, and she's a registered nurse, retired now, and she says there's a wait of 28 hours there. 28 hours couldn't mean 40 yet, no?
Yeah.
So
We came home.
she just had a knee operation. I says, can you drive? I couldn't drive. Well, I think, when you're not feeling well with the pain. So we drove, and I says, at least if we can always stop at Oxford
Yeah.
and go in there if we're stuck or something.
Tylenol did the trick.
We made Ottawa.
We made.
We made them all forward. When I went in, he says, well, have you got, I had gone there the week before. He says, if you're sick, you can't come back. Well, I said, I was here last week with the same problem. I don't know what it is. It's a pain here. I didn't know what it was. I know now. Anyway, so to make a long story short, they kept me in, and then I lost my doctor, and I spent 1 week sitting in the window looking outside. They didn't want to release me. They were trying to find a doctor that could help me. So that's why today when I saw this invitation and the word Canada, I said, I'm going to go listen. I'm lucky that I learned something.
Good.
And telling the people what I went through,
Yes.
maybe it helps you guys or something.
Oh, yeah.
No, that's-
Coming back to the palliative care,
Yeah.
I don't remember if it was on TV or somewhere. I heard an ad about a nurse having started a palliative care agency, but it was private.
Okay.
So I don't know if it is associated with you or it's different or,
Yeah.
and are your services for palliative care free?
Okay.
And the people who are doing it, like Harvey, we're talking about Harvey. Harvey does volunteer work at Briere,
Okay.
okay? And he's done a ton of courses for palliative care.
Mhm.
So he is kind of specialized in this.
Yeah.
Well,
So
it's been a volunteer.
he's been a volunteer,
For
but they have to
many
go through
years.
some type of training. That's what he told us.
Yes.
Yeah.
So, are
you?
your people doing the same thing?
Yeah, so I guess the best way to explain that is when you are ready for palliative care and you're at that end of life stage, you have choices. One, you can stay at home. One, you can go to a hospice. Or the third is if you're in a crisis, you can go into the hospital. If you choose to stay at home, that avenue, you have private or CCAC. So CCAC is all funded by OHIP. So you're not paying for any service. But in order for us to determine if what you qualify for or how much service we can give you, we need to complete an assessment. And based on that assessment, we would say, okay, you qualify at this moment for a nurse to come see you every day, a personal support worker twice a week, and a physiotherapist, let's say. And you qualify for, if you're at end of life, you qualify for a hospital bed at home. So based on that, we would come up with a palliative care plan that's fully funded. What people are finding at home is that sometimes that's not enough. So at that point, we refer them to those private agencies like at-home hospice or Nurse Next Door, which are those companies that are private that provide nursing assistance and personal support services, but there's a cost associated to it. So with the mix of both CCAC and private, a lot of people find like that's enough. Some families have really, really big families too, and they don't need us very much at all. So we send in the nursing and a little bit of personal support, And some people need a lot of us. So come the last days of life, sometimes we have nurses stay over for 8 hours at a time at patients' homes. That's funded by the government through CCAC. So all of our services are paid for by OHIP. So what we usually say is find out what you're eligible for through us first. We'll do the assessment, see where you're at. We'll let you know what you qualify for. And then if you need something above and beyond, like we do reassessments too, things change sometimes and you're able to qualify for more. But if you're not, then we would refer you to all these agencies that would do private assistance.
I read a book about palliative care, and this author recommends that you get all your family together and have them stay there 4 or 5 hours each through the night.
Yeah, that's usually the best to prevent burnout at that stage of life.
Yeah.
Some people, everybody is very different. Some people are at that end of life stage for a month or two. Some people are at the end of life stage for a week. So it's really hard to predict, but that's definitely great to help prevent burnout.
Yes.
But there are options too. Some people start at home and want to choose to end their life at home or for palliative care, but then realize, you know what, I don't want to be at home anymore. I want to do the hospice thing. So at that point, we do take hospice referrals, and or you call Elizabeth Briere and do the hospital referral through them, and can get admitted to a hospice. There are wait times for that sometimes, but it's not very long. And some people can't manage at home anymore and go into hospital, and then they wait in the hospital for a hospice then if they can't return home.
We don't have many hospices in Ottawa.
No, there's not many.
Maybe
There's the Rogers House for Children. There's Elizabeth Briere. There's yeah. There's a couple of.
Well, I put a paper together and it's on the internet, and
Good.
it lists them all.
Okay.
They're trying to build one in Canada now. Once they get the money, they've got the offices built, but they need the part where the beds go.
How about the caregiver? And because, I mean, maybe it's not the first time I heard that. Okay, people are at the end of life, and it would be the spouse. And let's face it, in the days now, I mean, you talk to a wife, a lady, she was here in Ottawa. I don't know where they were from. She was here with her husband. And there were no other support groups, no members of family. Maybe they were all over the place, California, Vancouver, name it. And she was exhausted.
Yeah.
So do you have any program for the caregivers?
So at that point where the caregivers get so burnt out or stressed out where they can't do it anymore, we do have some respite hours that we can provide. So like I said, we would authorize like a full 8 hours of nursing and then a full 8 hours of personal support and plan it so that most of the day is covered, or the overnights, cover the overnight so they can sleep. And then we would take over the care overnight. So we work with every family differently depending on what kind of supports they have. A lot of families who don't have a lot of family end up reaching out to friends and neighbors, and people are very good to assist at that time. But usually we do try and come up with care plans that are a little bit more creative to allow people to, we do a lot of overnight nursing and overnight personal support to allow the caregivers to sleep, because then when they're up every 2 hours giving medication, or up every 2 hours turning or changing a brief, then
we have a friend, okay, it's not the same situation. His wife has advanced stages of Alzheimer's. The poor man doesn't sleep. He just doesn't sleep because she wakes him up, she wanders around. You see, that's when I...
And part of the CCAC too is we manage long-term care applications. So, you know, there's retirement homes and there's nursing homes. There's a big difference between the two. Retirement homes are completely private. They're privately owned businesses, and they don't usually offer a lot of care. It depends what kind of package you get. But a nursing home is run provincially, and it's a program that we assessed for. So if you want to get admitted to a nursing home, like in that situation where if the caregiver is taking care of someone with Alzheimer's and they're up and their care is a lot, like they need help getting into the shower, they need help washing, they need help with meals, they need help with walking. At that time, they could complete an assessment for long-term care to see if she's eligible for a nursing home, and then she would get a placement
At
there.
one point, he told me that
That's a lot.
she was singing all night long.
Yeah.
Well,
Alzheimer's is
she
very
was in care
sad.
for, remember?
Yeah,
For a number of years, and then they find that she was so troubled that they had to ask him to take her out, because
Okay.
they couldn't handle her.
she couldn't handle the group.
No,
Yeah, so there are different nursing homes too that handle, there are some with specific Alzheimer's units.
yes,
There's some with locked units for people who wander a little bit more.
yes,
There's different ones based on
That's
your
why she should be
ethnicity.
that poor lady.
yes.
Yeah.
No, that's what we
But
keep
but
telling
you
him
know,
all the
I
time,
mean,
but
yeah, that's what we tell him. that-
but he
But
wants,
if he can call us, then we can coach them too. So the initial person when you call is called a referral specialist, and they can tell you where to call or what's going on. You just tell them what's going on with you,
Who you call?
and then they can give you
We did
information.
Champagne. We needed some lubricating gel or something.
Yeah.
And one of your,
Yeah,
Yeah.
she's went out of her way and gave us some information, where to go, who to call, who to see and all that. It was nice.
Yeah, and we have a website too. I'm not sure if you're very good with the internet. Our website has all the numbers,
Yeah,
all
yeah.
the programs for all of the Champlain region. It's a really great resource.
And I mean, a lot of seniors are on internet.
Yeah, no, I know. It's
They refuse to, like the brother-in-law is 90 and she's 87. No way.
She said, "I'm doing
Do
something
something
else,
with that.
something
the internet.
different."
No.
yeah, but that's why we still have the phone number too, so you
Yeah.
can call,
Yeah.
and that person has the internet in front of them with the same information that you would find there,
Yeah.
so they can.
Last week we received a call from a friend. She's calling me. She said, Suzanne, I'm going to die. I'm calling you to tell you I'm gonna die soon. I'm going to palliative care.
Mm.
And 2 days later she was dead.
We were
And
supposed to
we're
meet her
supposed to
today.
meet today.
Oh wow.
We don't know that person other than she was a neighbor of a friend of ours that died.
Mhm.
Yeah.
And I'm retired from the railroad and was a senior officer from the railroad. We have our dinner at a different place in Montreal, very close to her house, so I called him.
So we did
He
meet
says,
finally.
I'd like to go. And she says, well, I don't know if I'm gonna go, I'm not well. And she says, I'll take over. She called Suzanne on the 14th or 14th.
Yeah.
They accepted to come. On the 14th, she died.
Yeah. She called 70 people to tell them she will die soon.
Oh wow.
She has a 13, a family of 13. She called everybody.
7:25 in the morning, phone rings at our
Yeah,
house.
it's
It's a man's voice.
strong, and she
He
had
says,
cancer for 5 years, 8 months, bone cancer. And that was the
I'm
end.
so and so, I'm calling from a mother who wanted me to call you and tell you that well, here, I'll let you speak to her. He says, they've taken me into palliative care within an hour or so. And I just want to say a little goodbye to you guys.
So we're here instead of meeting her.
Wow.
What am I going to tell her? Best thing is just to listen and, anyway, let her do her wish. Anyway, sorry if we put this in there, March is May 17th.
No, that's okay. I'm sorry to hear that.
one of the things you mentioned when you wrote me is the oncology program.
Mhm.
What exactly is the oncology program that you,
Yeah, so that's what I was talking about earlier. The people who don't necessarily have a catheter, but who are actively getting radiation or chemotherapy, we have our oncology program, and we see them for pain and symptom management. So we do teaching in regards to that. We also have a home infusion program. Some people get chemotherapy at home. They go to the clinic, they get connected, and then they go home, and then they go to a clinic and get disconnected. So we have a program like that too. It's not for everybody, every type of cancer, it really depends, but that's a program that our oncology program oversees as well.
Assisting people.
Yeah.
And making
Yeah, and we
it
have care coordinators that are at the cancer center, at the Ottawa Hospital and at the Queen Crescent Hospital. So they're physically there. They see some of the patients sometimes, but usually when you're getting your chemotherapy, it's very overwhelming. So they call as well.
Yes.
But yeah, you don't necessarily need to have a tube inside of you to qualify for services.
You were talking about different services.
Yeah.
What type of health professionals? You're talking about personal service worker, nurses, physiotherapy, what else?
Yeah, so we have occupational therapy, physiotherapy. Do you know the difference between the two?
No.
Okay, so an occupational therapist, they would help more with your activities of daily living. Let's say you had a stroke and you have a hard time eating because you have weakness in your right arm. They would teach you what devices you can use, like reachers or special spoons that you could eat a little bit better with. They usually do all the assessments for the wheelchairs to see what kind of wheelchair would fit perfectly for you. So an occupational therapist helps more with your how you do your day-to-day things, like getting dressed and bathing. Physiotherapists, they help more with strengthening and mobility. So they'll give you exercise programs.
Yeah.
So these are like the people that you would see at a gym. Yeah, they make you work. Let's say you had a fall and you broke your hip and now you can't go up the stairs. They would come up with a program for you so that you would be able to go up the stairs. Yeah. Yeah, so that's the difference. It sounds kind of similar, but that's the main difference. We have speech language pathologists too. They do swallowing assessments for people post-stroke as well. We have social workers. So for clients who, sometimes we have clients in the community who are at risk of losing their home for whatever reason, or don't have running water, and they need a social worker to intervene and help with funding and things like that. So we have that service. We have nurses, personal support workers. They're not regulated. Those are people that help you with bathing and dressing. And nutritionists, dietitians.
We have a friend who had surgery in January. And it was a pretty extensive surgery. She has cancer of the tongue.
Okay.
And you were telling me, the nutrition, do you have people who will help for the swallowing and everything? When she came out of the surgery, she had a tracheostomy.
Okay.
And also, she had a tube for feeding. Now, she's still on baby food.
Yeah.
Okay. But she told me that, at the beginning she couldn't talk. She told me that she was seen for the swallowing problem at the general. How come she was not followed by you?
So sometimes some of the physicians want to follow specific patients in the hospital. So they want to do all the follow-up. They arrange for speech language pathology at the hospital. It really depends on the doctor. Sometimes doctors really want to follow their patients. Maybe there was a complication during surgery, maybe there's something specific. But if she would have been referred to us, then we would have been able to assess her and send a speech language pathologist to her. But really it depends on the physician.
Okay.
And let's say she is no longer seen by a speech language pathologist and she still wants somebody to assist her, she could always call us to see if she would qualify for our program.
Because first she said, I don't know where she had to get her food from. Because it had to be some kind of special food.
Yes, usually it's the pharmacies that source that formula, like the special formula, depending on what kind of nutrients they need. But if she's followed closely by a doctor and she's been seen in the hospital by, a lot of the hospitals have outpatient services now. So sometimes some of the hospitals that do knee replacements and hip replacements, they have patients go into their physiotherapy program. But depending on whatever their criteria is, the ones who don't get seen there get referred to us.
Okay.
So it's just, they're different ways.
You know, but for us, it's complicated.
Absolutely.
You know, it's, I mean, okay, how come she goes to the hospital, but so-and-so goes to CCAC, and what is the difference? Why?
Sometimes it could be resources. Maybe they only have 30 spots, and if they're full, they send a referral to us. Sometimes it's depending on the diagnosis or the surgery they had. That's the thing, every patient is different. There's no cookie cutter patient, so it's hard to dictate where someone goes where. But I definitely understand that it's difficult for patients to understand how it all works.
You made it very clear.
Yeah, could I have an extra one? My neighbor,
Yeah,
she's
absolutely.
handicapped, and maybe eventually.
Yeah, so people who
Yeah.
qualify for CCAC have an OHIP number. So we don't
Okay.
go to Quebec, people who have a CAPSA there.
Yeah.
There's a CCAC in Quebec called something different.
Yeah.
And yeah, so
So I'd like to thank you for
The information.
the information.
no problem. I'll leave, do you want me to leave this here? That way if anyone wants some of these later?
Maybe half of those.
Yeah, no, they gave me a lot. They
Yeah,
were-
no, we don't need all of them.
Okay,
Yes.
so I'll leave that. I can leave it at the front desk if you want.
No, Microsoft is really a meeting place.
Oh, okay.